Okay, so please, who is the rep for this group? Hello, can you hear me?
Yes, sir.
Yes,
Yes. Please, who is the rep?
sir. Jennifer and Louisa.
Are they with us?
Sir, please, we have about 16 reps.
So anyone? Okay. Okay, so if no rep is going to own up, then let me continue. I believe I was able to discuss the various targets we did the last time. We talked about the pharmacological receptors, we looked at enzymes, we talked about chiral molecules or transporters, and then we also talked about voltage-gated ion channels. And under pharmacological receptors, we talked
Sir,
about
please, we can't hear you well. Sir, we can't hear you well.
ligand-gated ion channels, which we give specific examples as the GABA A receptor. GABA A is gamma aminobutyric acid. And another example is the nicotinic acetylcholine receptor. We spoke about G protein coupled receptors, also called metabotropic receptors. We talked about the kinase link receptors and then the intracellular receptors as well. Okay. I believe I showed you the different types of ion channels. Please, did I do that? Did we look at this particular diagram?
Yes, sir.
Yes, sir.
All right.
Yes,
Then
sir.
let me continue from here. Okay.
Hello,
Now,
sir.
under the target, we said that, yes, please.
Sir, please
Please,
take your
to
time
ask of
because
a
we
rep,
can't hear
I
anything.
raised my hand, but I didn't hear
But
anything.
I am shouting, so please check your network, okay?
Please, sir, you asked of a rep. I put up my hand, but I didn't hear anything from you.
Okay, I actually wanted you to unmute yourself and say something. Normally, when I'm projecting, I don't really see the messages that comes up. Okay,
Okay.
that's
Sorry
fine. I
about
just
that.
wanted to go through the case study with you, but then we can drop that. Okay, then maybe later on we'll talk about
Okay,
it.
sir. Okay, thank you.
All right. Now, under the various targets, we talked about voltage-gated ion channels. Then under pharmacological receptors, we also mentioned ligand-gated ion channels. What is the difference between voltage-gated ion channels and then ligand-gated ion channels? From what we understood the last time, when we say a ligand-gated ion channel, there's a channel protein that is located on the cell membrane that allows for the movement of ions either into or out of the cell. And the gate or the key that opens that gate is a ligand or a drug. That is why we term that as a ligand-gated ion channel. Okay. Now, when you pick voltage-gated ion channels, it behaves just like the ligand-gated ion channel. The only difference is that the key that opens that door, the key that causes the ion channel to open to allow for the movement of ions into and then out of the cell is electricity, what you call membrane potential. That is what is able to open that particular channel. For ligand-gated ion channels, it's a ligand that opens it. For voltage-gated ion channels, it's electricity, changes in electricity, changes in membrane potential that is able to cause these channels to open. So if you look at the figure on the right, that is what we discussed the last time, the ligand-gated ion channels. So this specific ion channel opens to allow sodium to go into the cell, potassium to go out of the cell. when a specific ligand called glutamate binds, okay, glutamate is an example of a neurotransmitter. That's why we term this as a neurotransmitter receptor. So if you look at receptors such as the NMDA receptor, the receptor that ketamine blocks to be able to cause anesthesia, it's an example of the neurotransmitter receptor. Okay. If you give ketamine, it binds to where glutamate is supposed to bind. Once it binds to that place, it prevents glutamate from coming to bind. Once glutamate is not able to bind to the channel protein, it does not open. The channel protein does not open, then sodium does not go into the cell, potassium does not come out of the cell. In this case, the inside of the cell is not able to become more positive to allow for the generation of action potentials or transmission of stimuli. Okay. Now, this channel is also an ion channel that is gated by a ligand, which is calcium ions. So, in calcium ions bind to this channel protein, it opens and then allows for potassium ions to escape out of the cell. Similarly, you may have the cyclic nucleotide gated ion channels as well. In this case, the production of cyclic nucleotides such as cyclic AMP or cyclic GMP binds to this channel protein, cause it to open, and then the various ions can move either into the cell or out of the cell. Now, if you look at the diagram on your left, which is the voltage gated ion channel, these guys in quite a contrast way of working, okay, differs a little bit from the ligand gated ion channels, even though they all allow for the selective passage of specific ions either into the cell or out of the cell. The difference between the voltage and then the ligand gated ion channels is that for the voltage gated ion channel, if you notice the one on your far left, it is able to open to allow for the ion sodium to move from outside the cell into the cell. That is, it allows for sodium influx. But then the difference is that over here, you don't need a ligand to bind to the channel protein to activate it before your channel will open to allow for sodium to go into the cell. The channel has, or the receptor has, a specialized section. Okay, the portion of that protein is a little bit special. It is able to use that portion to be able to detect changes in electricity that is flowing along the cell membrane. You notice that eukaryotic cells have a phospholipid bilayer. Okay, the cell membrane of mammals is phospholipid bilayer. That phospholipid nature enables the creation of an electrical charge on each cell. So each cell has that ability. Now, for most cells, typically for neurons, that electricity that exists on the cell membrane when the cell is resting is around minus 70 millivolts. Okay. So naturally, there's an electrical impulse that exists across the cell membrane, and it's around minus 70 millivolts for neurons. Okay. Now, when the cell receives a stimulus, right? Let's say that someone slaps someone. That particular stimulus, noxious stimulus that the individual has provided, will have to be felt by these cells. All right. Now, when the stimulus is reaching the cell, the ion channels on it are able to sense that there's a change in the resting membrane potential. So when the neuron is at rest, it has a membrane potential of about minus 70 millivolts. But then the moment you slap the person, this particular membrane potential begins to change. Then it starts getting to the positive values. Okay, so the negative value starts decreasing. So you have minus 70, minus 60, etc. Now, when it's changing, then the ion channel here is able to use this special portion of it to sense that the electricity that exists on the cell membrane is changing. Once it's able to detect that change, then this particular ion channel will open, and then it will allow for the massive influx of sodium. So sodium is able to live in large quantities from the extracellular environment into the cell. When that happens, inside of the cell becomes more positive. So this resting membrane potential will now start going to 0 millivolts, and then it starts going to positive values. Once you hit the positive values, then action potentials are generated. So now impulses can be sent to the brain, and then the person can perceive that particular impulse as pain. So if you want to perform any procedure on someone. The person is involved in, say, an accident, and then there's a cut. You want to suture that cut without causing pain to the person. If you don't give anything and you put in your needles and whatever, they are going to cause the person to experience pain because that is the stimulus that you are going to supply. Once the voltage gated ion channels are able to sense that stimulus, that change in the membrane potential, they open and then allow for sodium to go into the cell. Once sodium goes into the cell, it's able to help the neuron to generate action potential. So it transmits the pain all the way to the brain so that it will interpret that as pain. So if I don't want the person to feel pain, then I can interfere with this particular process. So you can give a class of drug that we call the local anesthetics. Okay, can you give an example? Anyone with an example of a local anesthetic?
Lidocaine.
Lidocaine, okay, or bupivacaine, right? Now, if you give these medications, what are they going to do? If you give lidocaine waits for this ion channel to open. Once the ion channel opens, it will quickly rush in. So lidocaine will be somewhere here. Once the channel opens, lidocaine quickly rushes into the cell. When it goes into the cell, then it binds to the channel pore and then prevents the channel from opening further. So it physically blocks this side so that if the lidocaine is sitting there, then sodium will not be able to rush into the cell. If sodium doesn't rush into the cell, then there's no action potential generation. If there's no action potential generation, then there's no pain transmission. And then you're able to do your procedure without the person having to feel pain. So the difference between a ligand-gated ion channel and then a voltage-gated ion channel is that the ligand-gated ion channel opens to allow ions to move either into the cell or out of the cell when a specific ligand binds to the channel protein. But then a voltage-gated ion channel is able to move or is able to allow the movement of ions either into the cell or out of the cell when the channel protein senses changes in the membrane potential or changes in the electrical impulses traveling along the cell membrane. So that is the difference. The key to opening the door in the case of ligand-gated ion channels is a ligand, a drug, a chemical. And then the key that opens the channel in case of voltage-gated ion channels is voltage or electricity or membrane potential. That is the difference between them. An example of a drug that interacts with a ligand-gated ion channel are drugs such as ketamine, as I gave an example some few moments ago. Or you can talk of drugs such as diazepam, phenobarbital, okay, the drugs that secrete or helps with the secretion of insulin, the insulin secretagogues. They are able to work on ligand-gated ion channels. Then if you pick examples of drugs that works on voltage-gated ion channels, could include the local anesthetics, okay. They will identify channels that open when they are able to sense changes in membrane potential, then they will block it. We'll talk more about the mechanism when we are doing local anesthetics. But now what I need you to get is the difference between the voltage-gated ion channels and then the ligand-gated ion channels. The only difference is what causes the channel to open. For ligand-gated, it is a ligand, it is a drug, a chemical. For voltage-gated, it is just electricity, membrane potential, or voltage. Please, are you okay with that?
Please, you're going too fast.
Please go over.
I should go over everything.
Sir, please come
You
again.
are going too fast, to say.
Ligated.
We are understanding you, but you are moving too fast.
Finish. And we're
Okay,
to buy and join.
no problem. I'm going to go over. Okay. What I'm saying is basically
Thank
simple. All right. Let me just use some 2 sentences to summarize this. We said that an example of a pharmacological receptor or a type of pharmacological receptor is the ligand-gated ion channel. Okay. Then there's also another target aside the pharmacological receptors. It's called the voltage-gated ion channels. This guy. So all of them are ion channels. But then what is the difference between the voltage-gated ion channel and then the ligand-gated ion channel? First, the similarity. The similarity is that they are both able to allow for the movement of ion. So if you look at the voltage-gated ion channel, this is able to allow for sodium to move into the cell. It's able to allow for calcium to move into the cell. Or in some cases, you can have some voltage-gated ion channels that allows potassium to exit the cell. Okay. Some can also allow chloride to come into the cell. Similarly, for the ligand-gated ion channels, they also allow ions to move. So sodium can go into the cell, potassium can also go out of the cell. You can have potassium exiting the cell here, then sodium, potassium, being antiported in the third example. So the similarity is that they are both channels, they are both doors that can be opened into the cell to allow ions to either go into the cell or out of the cell. But then what is the difference between them? The difference is that if you pick the ligand-gated ion channel, the key that opens the ion channel for ions to be able to go either into the cell or out of the cell is a drug. Okay, it's a chemical, and you can term both as a ligand. So if I say ligand, I could be talking about a drug or a chemical. So when the drug binds to the receptor, that is the ion channel, then it's able to open it and then allow for the ions to move either into the cell or out of the cell. But then for the voltage-gated ion channel, you don't need any drug to cause it to open. All that the receptor needs is that it can use a portion of it, some part of the receptor, to sense that maybe the electricity that is flowing along the cell, the membrane potential, that's how we call it, is changing. Once it's able to sense that, then the channel can open and then allow for ions to move. So the key that opens a voltage-gated ion channel is electricity, or its voltage, or its membrane potential. Unlike the ligand-gated ion channels, that is a drug or a chemical. Please do you get it?
Thank you, sir.
Yes,
Please, the main
Now,
topic for discussion is it pharmacological receptors?
please, can you come again?
I'm asking the main topic for this discussion is it pharmacological receptors?
The main topic for this discussion is pharmacodynamics. So anything
Yeah,
pharmacodynamics.
like the topic we are treating right now.
Right now, I'm talking about ion channels.
I'm asking is it pharmacological receptors?
It's pharmacological receptors and then other targets, such as the voltage-gated ion channel.
Pharmacodynamics. So, okay, all right.
All right. Now, if you
Oh,
have an ion channel, there are several ways that drugs can interact with the ion channel to produce a therapeutic effect. So you may have several drugs that when you administer, they work on an ion channel. If you give someone hexametonium, if you give someone decametonium, if you give someone suxametonium or succinylcholine, the one that used to paralyze patients before surgery, okay, all these are drugs that can work on an ion channel, but then they may not work on the ion channel to the same extent, or the way that they are going to interact with the ion channel may be different. So you may have drugs that works on ion channels, that binds to ligand-gated ion channels or voltage-gated ion channels, and then the way that they interact with the ion channel will be different. Now, if you're able to identify how it interacts with the ion channel, then when it comes to reversal of the drug effect, or when it comes to more or less enhancing the drug effect, then you know exactly how to go about it. The strategy to use to be able to enhance or prevent the effect of that particular drug. Now, principally, there are two ways that you can interact with ion channels. Okay. The first way that you can do is that you can administer a drug that will physically block the ion channel. Okay. If you look at this diagram, you can give a drug. This is the ion channel. This is your cell membrane. So that's the cell membrane. And then this is the ion channel, the channel protein. It forms something that has a pore so that the ions will be able to pass. Now, you can give a drug that will come and sit in the pore itself and then physically block it. And typical example is the local anesthetic such as lidocaine. If you give these drugs, they wait for the receptor to open. Okay, the receptor for lidocaine or the local anesthetics is this particular receptor, the high frequency voltage gated sodium channels. Okay, that is the receptor that these local anesthetics will target. So they will wait for the receptor to open. Once the receptor opens, the local anesthetic quickly rushes in. Then it goes to hold the various edges, the various walls of the ion channel together, and then physically block it. So that if you have sodium here, and then sodium wants to come into the cell, it comes to meet the place blocked, physically blocked by the local anesthetics. So one way that you can interact with these ion channels using drugs to cause a therapeutic effect is to give drugs that can physically block the channel, right? So that ions will not be able to move. A specific example is what I gave, the local anesthetics, all of them, the Pivacaine, lidocaine, procaine, etc. Now, what you can also do is that you can give a drug that will not bind to the channel, that will not bind to the pore, but then it will bind to the channel protein itself. That is, it will bind to a portion of the ion channel. Then once it binds, it's able to modulate or change the way that the ion channel regulates, change the way that the ion channel opens or closes. And specific examples are drugs such as the benzodiazepines. Typical example of a benzodiazepine is diazepam, lorazepam, etc. Nordazepam. Okay, the benzodiazepines are able to bind to the channel protein and modulate the way that the channel opens to allow for ions to move. I'll later talk about diazepam and then one other drug. Now, the next class that is also able to bind to the channel protein are the barbiturates. Okay, an example of a barbiturate is phenobarbital, pentobarbital, thiopentone, amobarbital. All these drugs can also bind to the channel protein and then regulate or change the way that the channel protein opens to allow or disallow the movement of ions. So there are two ways that you can cause therapeutic effects using ion channels if you're applying drugs. One way is to give a drug that will physically block the space, block the lumen, block the pore, so that the ions will not move. And specific example is the local anesthetic. Or you can give a drug that will bind to the ion channel itself, the protein. Okay, it will bind to a portion of it. Then it's going to regulate the way that the ion channel opens. And there are several classes of drugs that can do that. Diazepam can do that. Phenobarbital can also do that. The sulfonylureas can also do that. Then some of the drugs that we use in management of hypertension, such as the calcium channel blockers, nifedipine, amlodipine, etc., can also do similar thing. They bind to the channel protein to be able to cause an effect. Now, when it comes to binding of the channel protein, there are also ways that the drugs can also do that. Now, if you look at the channel protein, let me give specific examples as the GABA A receptor. The GABA A receptor is the receptor that diazepam, phenobarbital all works on. Okay, those of us in the pediatric wards or the children wards, what do you use diazepam and phenobarbital for?
For seizures.
Yes.
For
So
convulsions.
seizures, convulsions, etc. Okay. Why is it that even though these guys are targeting the same receptor, why is it that there's a difference in their activity, the way that they are able to produce anticonvulsant effect? It all comes in when it comes to how they interact with the channel protein. So let's say that this is the GABA A receptor. These are the channel proteins, okay? And then it has this is the space. So you have your cell membrane here. This is outside the cell, inside the cell. So you have the iron chloride that is supposed to come through this channel into the cell. The reason why you need chloride is that when chloride comes into the cell, it makes the cell inside of the cell more negative. Once the cell becomes more negative, it becomes difficult to generate action potentials. So when someone is having convulsions or seizures because of hypersynchronous firing of the neuron, you don't need to generate action potentials further. What you need to do is that you need to inhibit those neurons that are working. So in this case, the GABA A receptor opens and then allows for chloride to come into the cell, make the cell more negative. Then the cell will become hyperpolarized. It cannot generate action potential. If there's no action potential, there's no stimulation. And then the seizures can abort or the convulsions can cease. So that is why you need the GABA A receptor. Now, it is called GABA A receptor because the endogenous ligand, the natural ligand that the body produces to bind to this receptor and stimulate it so that you can do whatever that you need to do without getting convulsions is because the endogenous ligand is gamma aminobutyric acid, GABA for short. So it's called GABA A receptor because the ligand that binds to it to activate it is called GABA. If GABA binds to the channel protein, let's say this side, the protein opens and then allows for chloride to go into the cell so that convulsion seizures will all stop. But then what happens? This thing is naturally produced. What happens if a patient comes and then the person is convulsing? You cannot give the person GABA. But then what can you do to be able to help the patient? There are two drugs that you can give. You can give diazepam or phenobarbital, and then they will be able to cause the seizures to go away. All of them are going to open the channel to allow for chloride to go into the cell. But how they do that is a little bit different. Now, phenobarbital behaves just like your endogenous ligand GABA, gamma aminobutyric acid. It means that if you give phenobarbital, it binds to the portion of the receptor that GABA was supposed to bind. So enzymes are like, or receptors are just like human beings. There are things that we prefer, and then there are things that we can just go along with. Some of you may want to eat maybe fufu in the evening, but then if you don't get fufu and then you get maybe wachi, you are okay with it. But it doesn't mean that you'll be satisfied to the same extent with those different foods. The same thing happens to the receptor. The receptor likes specific areas where it should be stimulated. So every receptor has that. On the channel protein or the receptor protein, there's a portion where the receptor would want to be stimulated by drugs. But then if you don't stimulate it there may be other areas, secondary areas where you can also stimulate to also cause the receptor to become active. Just that it wouldn't become as active as a drug that stimulates the receptor at the primary site. So the same thing happens to the GABA receptor. It has a primary site where it likes drugs to stimulate. So when GABA is available, it goes to bind to that primary site. And that primary site is called an allosteric site. That is the portion of the receptor where it likes to be stimulated. Okay. Now, if you give phenobarbital, phenobarbital will go and bind to that same primary site, that same allosteric site, and then it increases the duration that the ion channel stays open. So if in the absence of phenobarbital, the channel was opening, let's say 1 minute to allow for chloride ions to go into the cell. Once you administer phenobarbital, now the channel remains open for about 10 minutes. And that is going to increase the amount of chloride that can go into the cell so that the place can become more negative, more hyperpolarized, and then there wouldn't be the generation of an action potential. Then seizures will be able to go away. The problem with this approach is that because you increase the duration and then you have a massive influx of chloride ions, it
Hello,
causes
sir.
significant CNS depression. Okay. Now, when that
Hello, sir.
CNS depression happens, yes, please.
Sir, please. Some of us are really struggling to hear you. If you can please do something about your volume. Sorry for the interruption, please. I'm sorry.
Yes, please.
But
And
please,
as
we
I
are
said,
straining to hear you.
I'm really shouting. Okay, so kindly check your network. All right.
I've done it. I even left and came back, but it's the same problem.
All right.
So it's one of us.
So if you
Yeah,
give
please, it's true.
phenobarbital, please can you continue?
If you can get
If you
a
give
mic.
phenobarbital, okay,
Oh,
it binds to the site where GABA is able to bind, then increases the amount of chloride going into the cell. When that happens, it causes significant CNS depression. So it is not only the convulsions that will go away, the ability of the person to breathe will also be affected. Okay, the ability to form certain or cause certain procedures to occur within the brain, all of it is going to occur. So some time back, we used to give phenobarbital as a hypnosedative. So when someone is having insomnia, difficulty sleeping, you administer 5 milligram phenobarbital, then the person will probably be fine. But then later on, we realized that most people were dying out of that because of the significant CNS depression that was happening following the administration of phenobarbital. So we now shifted to the use of the benzodiazepines, such as diazepam. Okay. Someone is writing on my screen. Please, can you stop that? Then we shifted from the barbiturates to diazepam. Diazepam is able to cause CNS depression to take care of the convulsions that are happening. But then it doesn't cause that massive CNS depression that is associated with the phenobarbs, okay, the barbiturate. The reason why diazepam is associated with less CNS depression is that diazepam does not bind to the primary site. It doesn't bind to the orthosteric site where GABA binds. It rather binds to a secondary site, okay, another place on the receptor that can be stimulated, just that it wouldn't cause the same level of stimulation as the primary site. That is where your diazepam binds. And in this case, we call this site an allosteric site. So diazepam is an allosteric modulator of GABA A receptor activity, whereas phenobarbital is an orthosteric modulator of GABA A receptor activity. When diazepam binds to this allosteric site, it increases the frequency at which the channel is able to open.
You said the phenobarbital is orthosteric. The diazepam is. Hello, sir.
Yes, please, I'm listening.
Hello, sir.
Please, I'm listening.
Yeah, you are saying the phenobarbital is orthosteric. What of the diazepam? Can you change the word?
I said
Can you change the
orthosteric.
diazepam again? You said phenobarbital is orthosteric. What of the diazepam?
Orthosteric.
The diazepam. The diazepam is orthosteric.
Please, can you see my screen? Hello, can you see my
Yes,
screen?
sir. You can.
Okay.
Yes, sir.
All right. Phenobarbital binds to the primary site on the GABA A receptor, so it binds to the orthosteric site. This is orthosteric, the one that I have underlined. Please, can you see that?
Yes, please.
Yes.
Okay. Diazepam binds to a secondary site called an allosteric site. Please, can you see that?
Yes, please.
Yes, sir.
Okay. All right. Now, because it binds to the allosteric site, instead of increasing the duration of opening, it rather increases the frequency of opening. So if in the absence of diazepam, the receptor opens 5 times in a minute, once you administer diazepam, it's going to increase or open about 100 times in a minute. And that is going to increase the amount of chloride that will be able to gain the chance to go into the cell and cause hyperpolarization. But then it wouldn't be as much as the chloride that goes into the cell when phenobarbital is administered. So diazepam is able to manage the convulsions, but then it really does not cause that much CNS depression when compared to that of phenobarbital. It may still be significant to the extent that sometimes you may have to administer flumazenol to reverse that particular effect. And it's the reason why when a child comes with convulsions, sometimes the first drug that you give is diazepam. And then you repeat diazepam again. It is when diazepam is not working that you end up going to phenobarbital. Phenobarbital is more potent than diazepam. But then we did not start with phenobarbital because if you are not careful, you cause respiratory depression and then lead to the death of the patient. If you cause respiratory depression using phenobarbital, there's no antidote.
Sister Beatrice,
But then
please
if you
mute your.
cause CNS depression using diazepam, you can administer an antidote, flumazenol, and then you'll be safe. So in the hospitals, in emergency situations, you always walk around with flumazenol in your bags. So that once you give diazepam and it's causing respiratory depression, you administer flumazenol. But then if you give phenobarbital and it causes CNS depression, it causes respiratory depression, there's nothing that you can do unless you do mechanical ventilation for that patient. And it's the reason why you go with diazepam first. And when the patient is not responding, the patient is at risk of maybe getting or suffering from status epilepticus, then you can now go in and administer your phenobarbital. So in summary, there are two ways that you can use drugs to modulate the activity of an ion channel. You can give a drug that can physically block the channel pore. And typical example is a local anesthetic, such as lidocaine, etc. Or you can give a drug that will bind to the channel protein and change the way that the channel protein opens to allow for the movement of ions. Now, if you take that particular approach, then there are several ways, or there are two major ways that you can also administer drugs to change the activity of that particular ion channel. You can give a drug that binds to the same site where the endogenous ligand binds. That is the primary site, also known as the allosteric site. Or you can give a drug that can also bind to a secondary site of that same receptor, known as the allosteric site. And typical example is if you take the GABA A receptor that we use drugs on, stimulate, so that we'll be able to manage convulsions or seizures. You can give phenobarbital to bind to the allosteric site. You can give diazepam to bind to the allosteric site. Please, are you okay?
Yes, sir.
Yes, sir.
All right.
Yes.
Yes, sir. Sir, please question. So,
I'm going
sir,
to
it means
close this
that
section and then open it again because I can't see anything. People have written on my screen. So I'm going to reopen it again. Just a second.
Sir, please use your eraser to erase it.
I can use that, but I don't have time to be using eraser on everything. Okay.
Okay.
All right. Now, another example of a class of drug
okay,
that
sir.
also
Question.
any
Sir,
question?
I said question. Hello, sir.
Yes, please, I'm listening.
I was saying that with the with the voltage ion channel, this reaction can be altered by hello, sir.
Yes, I'm listening.
Sir, I'm asking a hello.
Please, I'm listening.
Yeah, I'm asking that meaning that the
Ion channel.
Please, are you still asking your question? Okay, I can't hear anything, so you let me continue. When the network is a little bit better, you let me ask. Okay. All right. Now, other classes of drugs that can also interact with the channel protein of ion channels to be able to exert an activity are the calcium channel blockers that we use in the management of conditions such as hypertension. Okay. More specifically, the dihydropyridines, such as nifedipine. You can get nifedipine in brands such as Adalat, Neficard, etc., etc. Okay. Then there's also amlodipine, right? Please, there's no P here. It's amlodipine. Then you can also have felodipine. What these guys will do is that they identify the L-type calcium channels, then bind to the channel protein, cause it to close, so that calcium will not be able to go into the cell. In this case, you are talking of the smooth muscle cells of the blood vessel. Okay, they need the
hello, sir.
calcium to be able to cause vasoconstriction. So once the channel
Hello.
is blocked, okay, and then the calcium is not moving into the cell, then vasoconstriction will not happen. Automatically, you're going to get vasodilation. That's why they lead
Hello, sir.
to
My
a
next
drop in the blood pressure. Okay. Yes, someone is asking a question.
yes, sir. Yes, the
Please,
network.
please,
I
have
was
we
asking that.
ion channels to
Oh,
another?
I was
Please, can you come
asking
again?
that. Does it mean that the voltage ion channel can be altered by uh, what you just explained that when the drug is being introduced, like for example, when someone is having convulsion, the means by which it can be stopped is that, for example, the filter attacks the primary site, that attacks the second, the voltage ion channel can be altered.
The line was breaking, so I couldn't get most part of the question that you asked. Can you just summarize the question in, let's say, a few sentences and let me hear it? Then I'll come up with a solution.
Oh,
Please, can you hear me?
Yes, please.
Yes, please can you ask your question again? I couldn't get anything that you said.
Hello, sir.
Yes, please. Yes, please, I'm listening to your question.
Hello, sir. Can I go on? Sir, please, can you breaking up?
Okay, maybe
Hello, sir.
I can make yes, please.
If Amasis line is breaking up, can I ask my question,
Yes,
please?
you can. Yeah, the lady whose line is breaking up, you can type your question and then I'll look at it. Okay.
Please, I'm asking, are we done with the ion channels and moving on to a different type of, they are all under ion channels, please?
Please, I'm still talking about the ion channels. Okay.
Okay, thank you.
All right. Please, any other question?
No, sir. Please, you can move.
All right.
The network was just out. I was saying that, does it mean that the voltage ion channel can be altered? That was the question I asked.
Does it mean that the voltage gated ion channels can be altered? Please, is that your
Yes,
question?
please.
Yes, you can alter the activity of voltage gated ion channels. That's why you give local anesthetics. Okay. If you don't change the way that they work, then the person will be having pain. The person will be experiencing pain. So when someone, maybe you have a knowledge comes in for the first labor, right? Definitely the probability that the person is going to tear is very, high. For some of you, you guys are midwives, right?
Yes, sir.
Yes,
Okay,
sir.
then let me say this. I don't know how, I don't know what is happening, but the Ghanaians don't like using local anesthetics. So the person comes in, you are very sure that at the end of labor, this person is going to tear. So you want to do an episiotomy for this person. So you just time your contract. Some don't even time the contract. They just take their scissors and then they cut. That's very barbaric. Now I don't really have an issue with that because sometimes because of the labor pain, it more or less mixes and then they are not able to feel what you are doing. But then now that labor has, maybe you are done, the person has given birth, right? And then you want to go in and then suture what you did. Instead of giving something to numb the pain, they just go in and then they start suturing.
Hmm?
Have you seen some before?
Yeah, yeah.
Yes, sir.
Usually
Okay.
say the yes.
Now that is so unnecessary. You are just causing too much pain to the patient, which is not right. Okay, so you can just administer a local anesthetic. What you are giving a local anesthetic is that you are just interrupting the transmission of pain. Because what you are doing to the patient is going to cause the person pain. That particular activity is going to stimulate those voltage gated ion channels, allow sodium to go in, and then pain will be easily transmitted all the way to the brain. The person is going to see that as pain. So if you give a local anesthetic, it will block that particular voltage gated sodium channel. And then the person will not be able to transmit the pain all the way to the brain. So in this case, you're able to do your suturing without causing the person unnecessary pain. Please, do you get what I'm trying to say?
Yes, sir.
Yes,
Okay.
sir.
Yes,
I
sir.
hope nowadays you give local anesthetics and stop doing what normally is done in the various facilities. Okay.
Yes,
All right. We'll
sir.
later talk about local anesthetics administration at some point of your study. Please, any further question before I move on?
Every day I should tell you to send it.
No, sir. Please continue.
Okay.
Yes, sir. I have a question.
Please, what's your question?
Please, we were talking about the two ways to modulate the action of ion channels. Does it apply to both voltage gated ion channels and then the ligand gated ion channels?
Okay. So for voltage gated ion channels, most often what the approach that we use is that we block the channel pore instead of the channel protein. Okay. But for the ligand-gated ion channels, what you often do is that you block or you modulate or you bind to the channel protein itself. Please, are you okay with that?
Yes, sir.
Yes. But then there are some few instances where you can give drugs to block the pore of a ligand-gated ion channel. And typical example is you don't see this drug in the clinic, right? It is used experimentally to induce seizures, right? Now, it's called picotoxin. If you give picotoxin, what it does is that it identifies the GABA A receptor. Then it goes to block the pore of the GABA A receptor so that chloride will not be able to go into the cell. If chloride is not able to go into the cell, inside of the cell becomes more positive, and then the cell becomes prone to hypersynchronous generation of these action potentials. And eventually, what happens is that the person starts convulsing or having seizures. Okay. So for ion channels, you can actually use both strategies. But for the voltage gated ion channels, oftentimes what we do is that we block the channel pore. Okay. But you can have some few instances where you can also interact with the channel protein. Please, are you okay with that?
Yes, sir.
All right. Okay. So if there are no questions, then let's continue. So I was given examples as the calcium channel blockers, the fedipine, amlodipine, etc., that can be used to reduce blood pressure by blocking calcium channels, the L-type calcium channels. Okay, they bind to the channel protein and cause it to shut, right? So that calcium is not able to go into the smooth muscle cells of the blood vessel. Now, there are other classes of drugs, such as the ones that we use in diabetics, the insulin secretagogues. And typical example is a class known as the sulfonylureas. And I think on the market or in the facilities, what you often come across is glibenclamide and then gliclazide. Please, have you heard of that before?
Yes, sir.
Yes, sir.
Sir.
Okay. Now, how these guys work is that they are able to enhance the production of insulin by the beta pancreatic cells. Now, insulin is produced by virtue of what we call exocytosis. And to be able to do that, they block, yes, please. Now, to be able to do that, what these guys do is that they block a specific ion channel, the potassium ATPase channel, found on the beta pancreatic cell. And once they are able to do that, then they can enhance the release of insulin by causing their exocytosis. So they also bind to the channel protein of ion channels, and then they are able to cause these therapeutic effects. Okay. So we've already looked at this. Now, I don't want to bore you with the signal transduction of ion channel, but then basically what I need you to know on this slide is the various examples of receptors that can be classified as ligand-gated ion channels. So specifically, you may have the nicotinic acetylcholine receptor. That is the receptor that acetylcholine binds to on skeletal muscles, the NM receptor, and also in the ganglion, the NN receptor. These guys are all ligand-gated ion channels. Then you also have the GABA A receptor. GABA is gamma aminobutyric acid, as we said earlier. And two drugs that you can have interacting on these are the benzodiazepines, such as diazepam. You can have the barbiturates, such as phenobarbital, working on this same receptor. Now, you can also have the glycine receptor. Glycine can also bind to glutamate receptors, more specifically the NMDA receptor, N-methyl D-aspartate receptor, the receptor that ketamine binds to. Okay, is also a G protein coupled, sorry, a ligand-gated ion channel. Now, serotonin receptors, there's a type of serotonin receptor, a subtype of it called the serotonin receptor subtype 3, 5-HT3 receptor. 5-HT is 5-hydroxytryptamine. It's another name for serotonin. Okay. The type 3 receptor is an example of a ligand-gated ion channel. Have you heard of ondansetron before?
No, no, sir.
Somebody in
No, please.
oncology.
Please.
Okay, so ondansetron,
Sir.
ganishitron works on these receptors. Okay. Now, serotonin has a lot of receptors. The type 3 receptor specifically is a ligand-gated ion channel. The rest of them will be G protein coupled receptors. Okay, as you see very soon. Now, by way of identifying ion channels, all ion channels have what we call a pentameric structure. The protein that you see that forms the pore for the ions to pass is made up of 5 different subunits. All ion channels will have that particular makeup. It has 5 different subunits that forms the main protein that becomes the ion channel. Now, what brings about the differences in various ion channels is the makeup of the 5 subunits. For instance, if you pick the nicotinic acetylcholine receptor, what I've shown over here, the nicotinic acetylcholine receptor has an alpha subunit, another alpha subunit, so 2 alpha subunits, 1 beta subunit, 1 delta subunit, and then 1 gamma subunit, making 5 subunits. But then if you pick something like the GABA A receptor, which is also pentameric, it has 2 alpha subunits, 2 beta subunits, and then 1 delta subunit. There is no gamma subunit. That is how come they differ in terms of the selection of the individual ligands from each other. Okay, it's because of the makeup of the various subunits. So what I needed to know on this slide is the various types of receptors that can belong or that can be classified as ligand-gated ion channels. Then also notice the type of or the kind of drugs that can be used to modulate the activity of these receptors. Now, before we go on to the G protein coupled receptors, any question with the ion channels? Where did you get lost?
When you were explaining the examples there, the 580s and others, you were mentioning some words you know even call before.
So 5-HT3 is 5-hydroxytryptamine, also called serotonin. Have you heard of serotonin before?
Yes, please.
Okay,
Yes,
so that is serotonin that I'm talking about. Okay, yes. So this guy, serotonin, it causes a lot of, if the levels are different, it causes some bit of neurological problems, okay, depression, etc. All right. Okay. So these are the examples that I just need you to look at. I've already given you examples under each of them for drugs that can interact with this type of receptors. Okay. All right. Please, any other question?
Please, sir.
Mm-hmm.
When you were explaining on the ion channels, or you were mentioning amlodipine and the rest. Can magnesium sulfate fall under them?
And hydrogen sulfate?
Magnesium sulfate, the one we use for our eclampsia phase, no? You know.
Yes, max off is just supposed to disrupt the movement of other ions so that you don't cause excitotoxicity. Okay. Magnesium is a divalent cation. It's Mg2 plus. All right. When it's in the body, it
So
can confuse the body into picking other ions such as calcium, so that you are able
that
to
fall under.
prevent the stimulation of these neurons. So yes, it affects the movement of ions.
Okay. Thank you, sir.
Yes. All
Sir,
right. Yes, please.
hello, sir.
Please, I'm listening.
Please, the glycine, please, the glycine, can you take that point again? You said it binds with what? The glycine.
Okay, there's a glycine receptor. Now, in the body, in the brain, there are two major types of neurotransmitters. We have the excitatory neurotransmitters and then the inhibitory neurotransmitters. The excitatory neurotransmitters are glutamate and then aspartate. When they are available, they're able to cause generation of action potential. You become excited. So as I'm talking, it's because glutamate, those guys are working. Okay. And then you have the inhibitory neurotransmitters such as GABA and then glycine, so that they will keep the excitatory ones in check, so that you don't stimulate your brain so much and then get convulsion. So there's the GABA receptor, there's the glycine receptor. And I wanted to also say that there are some glutamate receptors that glycine can still bind. So if you look at the NMDA receptor, it still has a portion where glycine can stimulate. That's why I wanted to point out. Please, are you okay with that?
Yes, please. Thank you.
Okay. All right. So G protein coupled receptors. Now, when we say a receptor is a G protein coupled receptor, all that we are trying to say is that this is a protein that is located on the cell membrane or as part of the cell membrane that is coupled to what we call a G protein or a guanosine protein. Now, there can be two different types of G proteins that this receptor binds to. It can bind to guanosine diphosphate or guanosine triphosphate. Now, whichever of these that it binds depends on whether the receptor is active or inactive. So if a G protein coupled receptor is inactive, it means that there's no drug stimulating the receptor. Then in that moment, in that inactive state of the receptor, it binds to what we call guanosine diphosphate. By the moment you introduce a drug, it binds to the receptor and stimulates it. The guanosine diphosphate will leave, and then guanosine triphosphate will come and bind. So a G protein coupled receptor couples to guanosine diphosphate in its inactive state, and then guanosine triphosphate in its active state. Now, typical example is adrenaline. Okay, let's say that someone is, or the person is having dry mouth, and then the person is complaining so much because their mouth is dry and etc. So you want to give a drug to be able to manage that condition. It's called xerostomia. Now, if you give a drug that looks like acetylcholine, okay, it can stimulate the production of saliva in the person's mouth. Not only the production of saliva, but then the production of body secretion, body fluids, including the ones that you find in the lungs. Okay, so that you can moisten the respiratory tract, moisten the GIT, etc. Now, in the absence of the drug that you are going to give, that particular receptor is bound to guanosine diphosphate. But the moment you introduce a drug and then it binds to the receptor, stimulates the receptor, the guanosine diphosphate will leave, and then guanosine triphosphate now comes in and then bind. Now, once the GTP is there, the receptor is active to be able to mediate all the actions that you need. In this case, the production of the saliva. Okay. Now, let's say that someone is having this. So you give a drug for the person to be able to produce the saliva, or the person was having constipation. So you give the person a drug to increase gastric secretions so that the person will be able to get diarrhea or you'll be able to manage the constipation. What happens if the receptor remains active forever and ever? It means that the person will keep on producing secretions. You keep on producing these saliva, you keep on producing the pulmonary secretions. And eventually that individual is going to drown in his or her own saliva because you are producing too much. So in order to prevent that from happening, naturally, that particular receptor, the G protein coupled receptor, comes with an enzyme called a GTPase. So this is the enzyme. The activity of the GTPase is to come in and then terminate the activity of the G protein coupled receptor once you've achieved what you want to achieve. GTPase is guanosine triphosphatase. Okay, so in the inactive state, you have guanosine diphosphate binding. When the receptor becomes active, you have guanosine triphosphate. It means that there is guanosine with 3 phosphate groups. Guanosine diphosphate is guanosine with 2 phosphate groups. So when the receptor is bound to guanosine with 3 phosphate groups, it is active. The person is producing saliva. But then when the person has enough of the saliva, then this enzyme will come in, the GTPase. Then it will come and take off 1 phosphate group from the GTP and convert it to GDP. We are saying that anytime the receptor binds to GDP, it is inactive. So in this case, the enzyme is able to inactivate the active receptor so that the person doesn't end up producing too much of saliva and then drowning in his or her own secretions. The same way, if the person is having constipation and give the medication and the person is producing gastric secretions, at some point, the GTPase will come in, take off 1 phosphate group from GTP so that it will be converted to GDP. In that case, the receptor will become inactive and the production of the secretions will go down. So in conditions such as cholera, okay, the bacteria produces a toxin that comes in, binds to this enzyme, and then inactivates the enzyme. So that when the person is producing the secretions, the diarrhea, this enzyme is not available to go and inactivate the receptor to prevent the diarrhea from progressing or to stop the production of the secretion. So you have this enzyme pre-packed with the receptor so that it can regulate the activation of the receptor to prevent excitotoxicity or to prevent the appearance of toxic effect out of overstimulation of this particular receptor. Please, do you understand?
Yes, please.
Yes, sir. Yes, sir. But please take care from the. You are saying that with the G protein couple receptors, they are on the cell membrane, and when they are
Please, can you come
inactive
again?
state. So when they, I'm saying
Hello, can you
that,
come
can
again?
you take it from? Hello, sir. I was saying that, can you take it from where you said these G protein couple receptors are found on the cell membrane, and the G protein receptors are inactive. So when they bind and then they become active, like you were using the saliva as an example. So when they are in
Mhm.
the GDP, when they are in the GDP and then they've been activated and now they are producing a lot of saliva, they need to be controlled. So the GTP, the GTP, the
Enzyme.
the GTP has
Yes, the
a
enzyme
guano
comes in.
Yeah.
Mm.
yes, the guanosine triphosphate will come in, and then one of will interrupt with the activity and take it back to the GTP to make it inactive. Is that what you said?
That is exactly what I'm saying. I couldn't hear some part, but then for the part that I heard, that's exactly what I'm saying. Okay. So you have this
Thank you.
enzyme there to bring it back to GDP to inactivate the enzyme. Okay. Now, if you have a J protein coupled receptor, its activation, okay, is associated with two things. If you stimulate a G protein coupled receptor, it's either you are going to increase an enzyme activity or you are going to change the way that a particular enzyme is going to work, what we call a target, or you change the way that a particular ion channel is functioning. Now, that ion channel that I'm talking about is the cyclic nucleotide gated ion channel, the one that we mentioned under the ligand gated, because that cyclic nucleotides are only produced when there's an activation of the G protein coupled receptor. You see that very soon. But for now, what I need us to appreciate is that anytime I give a drug that works on the G protein coupled receptor, it will either lead to the changing of the activity of a particular enzyme, or it will lead to the activity of or modulating of the activity of a particular ion channel. Okay, that is the cyclic nucleotide gated ion channels. Now, we could go on and on with the signal transduction of G protein coupled receptors, but then I'll not bore you with that. Earlier on, I said that G protein coupled receptors can also be called metabotropic receptors or 7 transmembrane spanning receptors. The reason why we call them that is that if you look at the structure, this is the cell membrane. So a G protein coupled receptor goes around the cell membrane 7 different times. Okay, that is why we call it a 7 transmembrane spanning receptor. Now, typical example are the receptors that acetylcholine binds to on smooth muscles. Okay, we call that the muscarinic receptors. Muscarinic receptors are G protein coupled receptors. There are 5 different subtypes that can regulate a lot of activity, from slowing down the heart to causing vasodilation to causing bronchoconstriction and causing asthmatic attacks, etc. Okay, these muscarinic receptors are the receptors that acetylcholine works on, and then they are G protein coupled receptors. Similarly, the receptor that adrenaline works on, or noradrenaline, isoprenaline, right, works on are also G protein coupled receptors. There are also the receptors that you give beta blockers to block. So propranolol, bisoprolol, atenolol, etc. They are given to block this particular receptor. It is also a G protein coupled receptor. You have alpha and then beta. Then dopamine receptors are also G protein coupled receptors. There are 5 different subtypes, D1 to D5, but then you can divide them into 2 major subtypes, D1 like and then D2 like. Then, if you remember, I said that serotonin receptor type 3 is a ligand-gated ion channel, and then the rest are G protein-coupled receptors. So these are the rest, okay? The rest of the receptors that serotonin binds to. Then, if you give morphine or codeine or oxycodone to cause analgesia, the receptor that they bind to, the opioid receptor, specifically the mu opioid receptor, is also a G protein-coupled receptor. Then, when you take caffeine, okay, theophylline, etc., the what we call the purines, the receptors that they also bind to adenosine, etc., are also G protein coupled receptors. So most of the drugs that you be coming across in the facility are drugs that works on G protein coupled receptors. I'll not talk so much of their signals transduction, but then I'll expose us to a very some small part of it to be able to help us understand the way that these guys are able to work, so that you don't end up mistakenly using some drugs together with them and then causing our patients to suffer. I'll later give you a case study on that. Now, we said that if you give a drug that works on a G protein coupled receptor, it will lead to the activation of either an enzyme or an ion channel. These two are called effectors. Okay. Now, there are several enzymes that can be activated following the stimulation of a G protein coupled receptor. These are just a few of them. First, you can have the stimulation of an enzyme called adenylyl cyclase or adenylyl cyclase, depending on which authority that you are looking at. Okay. Following the stimulation of adenylyl cyclase, this enzyme can catalyze the conversion
Oh,
of
sir, you brought
ATP to
another
what
Africa.
is called
Hello, sir.
cyclic AMP.
Hello.
Cyclic AMP is a second messenger. Okay. Then you can have
Hello,
another
sir.
enzyme also called, yes, please. Please, can I finish with this? Then I'll come back and pick your questions. Okay. You can have another enzyme called guanylyl cyclase. Guanylyl cyclase will lead to the production of a second messenger called cyclic GMP. Guanylyl cyclase catalyzes the conversion of GTP to cyclic GMP. Now, a second messenger is basically another chemical that you are calling in to come and help with the drug action, for you to be able to obtain the effect that you want to obtain. Now, if you want to use drug to bind to every receptor in the body to be able to cause a specific effect to happen, then you may need a barrel or maybe a gallon of the drug to be able to do that. Now, what helps drugs to be able to exert the effect that they exert in minimal quantities is the presence of what we call second messengers. Second messengers are basically, for instance, if, all right, for instance, I want to maybe sit in the consult room to become maybe a clinician to be able to help patients in a day. I can see maybe 15 patients tops, or maybe 20 patients tops. If I want to help 100 patients or 150 patients in a day, how can I do that? I need people to come in and then help. Those will become my second messengers. Okay. So I'm going to, instead of becoming a clinician, I'll become a teacher instead. So I'll teach those clinicians and then they will go out and then manage the patients. So that in a day, I'll be able to treat 100 or 150 patients. All right. So they will be acting as the second messengers. And then I am going to be the target or the effector. So when you give the drug, adrenaline, it will have to identify a target that is the enzyme, activate the enzyme. Then the enzyme will help you get a lot of these second messengers. Then those second messengers will go and bind to a lot of proteins so that they'll be able to give you the effect. And then you don't have to give so much of the drug, just a little amount of the drug, and then you have an amplified response. Okay. So if you have stimulation of this enzyme, adenylyl cyclase, it gives you the second messenger cyclic AMP. If you have guanylyl cyclase, it is going to give you cyclic GMP. Phospholipase C is going to give you these second messengers, diacyl glycerol and then inositol triphosphate. Phospholipase A2, which is involved in inflammation, is going to give you a second messenger called arachidonic acid. Then you have all the other enzymes or the other ions also coming into play. So these are the effectors that the stimulation of G protein coupled receptors will lead to the activation. And then eventually they will also give you these second messengers to enhance or propagate the signal so that you'll be able to get better therapeutic effect with very minimal amount of the drugs. Okay, please, any question?
Sir, please, the diagram before the picture before this, I didn't understand well. The where you have the seven mining was the hand, this one.
Okay,
And
so
it
this is a protein. Okay, yeah, this is the first part. So this is the number of times that it goes around the cell membrane. It's called signal transduction, right? I don't want to go into much details in that, but I just need you to appreciate the fact that it goes around the cell membrane 7 times. So this is the first one, the second one, the third one, the fourth one, the fifth one, all the way to the seventh one. The only receptor that does that is the G protein coupled receptor. And that is why we term that as a 7 transmembrane spanning receptor. It goes around the membrane 7 times. Please, are you okay with that?
yes, sir.
All right. Please, any other question? Okay, if there are no other questions, let's try to. Yes, someone's hand is up. Please, you can just unmute yourself and ask. Okay.
Say, please, can you throw more light on the infectors for me? Thank you.
Please, can you come again?
I say, can you please throw light on the infectors and the second messengers? Thank you.
I should throw light on the receptors and the second messengers.
The infectors.
Okay. All right.
Thank
What
you
I'm
very
saying
much.
is that if you have a G protein coupled receptor and you administer a drug to bind to it, for instance, you have adrenaline. Someone's heart has stopped beating. Okay. So you administer adrenaline into the person's heart. The heart is going to start beating again. How? When adrenaline is available, it binds to a G protein coupled receptor located on the heart called the beta adrenoceptor. Once it binds to that receptor, it leads to the activation of an effector, okay, an enzyme called this adenylyl cyclase. That adenylyl cyclase is an enzyme, and it will also convert ATP to work for a second messenger, that's the cyclic AMP. Now, this guy will be available in a lot of, let me say, concentration, very high concentration, a number of them. So just one molecule of adrenaline can cause the production of about 100,000 or 10,000 cyclic AMPs. Then these cyclic AMPs, being the second messenger, will then go and bind to the various targets to cause the heart to now start beating again. If you wanted to use adrenaline to bind to each of these targets, then you have to go and buy a gallon of adrenaline before you can do that. But then with the availability of the cyclic AMP or the second messengers, you are able to bind to these targets with minimal amounts of the drug and be able to exert a therapeutic effect. Please, are you okay with that?
Yes, please. Thank you very much.
All right.
Don't get down. Hey.
Now, I'd wanted to use this to explain everything to you, but then because I couldn't get any feedback, I decided to leave this. Normally, I base on what you already know, then I'll start teaching from there. But then we can always go back. Okay. What the import of what I wanted you to. Okay.
I said sit
Please,
down.
can you hear me?
Sit down.
Hello, can you hear me?
Yes.
Yes,
Yes,
sir.
We can
Yes,
hear
sir.
you. Daumevis, please
Unfortunately,
mute your mic.
I'm having a
We
lot
are
of
not
there's
here for
Yes,
you.
please.
thunderstorms here. Okay, because of the rains. So what I'll do is that the next time that I'll meet you, right, I'm going to use
Yes,
these
sir.
cases. Then we'll try to
I'll
use
hear
it
you.
to understand the
The best.
pharmacodynamic principles that you've explained.
Thank
How
you. The
do
best for
the
us.
various targets that we've spoken about come in to fit into this scenario? Please, are you okay with that?
Yes, sir.
yes,
Okay.
sir. Yes,
So
sir.
in order to
Thank you.
prevent lightning from passing through my ears, let me end the class here. I'm going to see you some other time, okay?
Thank
Okay,
you,
sir.
Thank
sir.
you,
Alright, sir. Thank you,
All
sir.
right.
thank
Thank you
you.
very
Good.
much for your
Thank
time. We'll
you,
see
sir.
you next
Thank you, sir.
Wednesday.
Thank you, sir.
It is a recording.